So what is the definition of acute kidney injury? Acute kidney injury is nothing but the abrupt decline in the glomerular filtration rate. So whatever is the normal GFR of an individual, if there is abrupt decline, then you're going to call it acute kidney injury, irrespective of the cause. So what happens when GFR declines? There is reduction in the excretion of waste products, and these waste products are going to accumulate. So this is the definition in a broader sense. Okay. Now what is it technically? If there is increase in serum creatinine of 0.3 milligram per deciliter or more within 48 hours of observation. So what does this mean? You have a patient, Mr. A, admitted, imagine on Monday, and you do his testing. Okay, creatinine testing, you do his whole panel, and that day creatinine is 0.8, right? Then you again repeat on Wednesday, assume the patient is admitted in ICU because of some reason, sepsis. And that day creatinine is 1.2. Okay. So this increase, that is 0.4, which is more than 0.3 increase in creatinine, is to be considered as AKI. Now, one of the common mistakes that is done is, see, for example, assume the patient's baseline creatinine is 0.4 and then it increases to 0.7. So this is 0.3 milligram per deciliter increase. Just because this creatinine is in the normal range does not mean that the patient does not have acute kidney injury. It means that the patient has acute kidney injury. Okay. So we should not think that just because the creatinine is in normal range, it is not acute kidney injury, because early diagnosis helps in management of acute kidney disease by a huge deal. Okay. So that is one important point you have to remember. That is first thing. Second thing is, if there is increase 1.5 times baseline or greater within 7 days. So the first definition we took 48 hours, right? Now the next definition we are using 7 days. So in 48 hours, if it is more than 0.3. In 7 days, that is 1 week, that is, it is 1.5 times the baseline. For example, you assume Mr. A has creatinine of 1. Okay, so for ease of the understanding. So this, you assume patient has this on Monday. So you take this next Monday, that is after 7 days, if the creatinine is 2.5, then also you assume this to be AKI. So this is probably, if the patient is in ICU setting or somewhere where more frequently you're using, this is an OPD basis where the patient might come back to you after 1 week and then you see 1.5 times elevation in creatinine from the baseline. That is 1 plus 1.5, 2.5 will be the absolute value if the starting creatinine is 1. Okay. So this is about creatinine. So one way you can use to define acute kidney injury is by using the creatinine. The second is by using urine volume. So it is less than 0.5 ml per kg per hour for 6 hours. Okay. So if urine output, for example, it's a 60 kg person, in ICUs and all, we'll be monitoring hourly, right? So if it is less than 30 ml for 6 hours, then also patient has AKI. So in an ICU setup, you are not waiting for creatinine to elevate, maybe because it will take 1 or 2 days for creatinine to elevate. I'll be talking in detail about this in diagnosis and management of AKI, that is AKI part 2, as to how creatinine is not a very good marker of acute kidney injury. So in that situation, urine output is very sensitive. That is, if urine output is reducing earlier on, even before creatinine increase starts, then you can use it to define acute kidney injury. So definition is less than 0.5 ml per kg per hour for 6 hours. So I hope you understood the definitions, the various definitions of acute kidney injury. So one is in 48 hours, if creatinine is elevated more than 0.3. Next is in 7 days, increase in more than 1.5 times the baseline. Next is if urine output is less than 0.5 ml per kg per hour for 6 hours. Okay. Coming to the etiology, this is the age-old classification that we have been seeing from MBBS time, where we classify it into pre-renal, intrarenal and post-renal, right? Now, intrarenal, if this is the kidney and this is the renal vein, renal artery, and this is the ureter. So, pre-renal, it has to do anything with vasculature or whatever blood is there inside the vessels, something to do with it. Intrarenal is when it comes inside the kidney. The cause of acute kidney injury comes inside the kidney. And post-renal is when it happens outside, after the urine leaks outside the kidney, or it is in the collecting duct system, okay, which might be collecting duct pelvis, or it's in the urinary tract, which involves the pelvis or the ureter or the bladder, okay. Now, intrarenal further can be classified into vascular, glomerular, tubular, interstitial. So, if you take the cross section of a glomerulus, cross section of a renal biopsy, you see glomerulus. Glomerulus, the afferent arteriole comes and becomes glomerular capillaries, goes as efferent arterioles. Apart from this, that there is interstitium, and there is going to be tubules, and there are going to be these blood vessels. So, which are the four compartments in this? So, one you see is vascular. The second you see is interstitial. Next you see is glomerular. After that, what you see is tubular, right? So these four components, if it is, once AK comes, you have to distribute them into these. You can see whether it's pre-renal or post-renal. If not for this, if it is intrarenal, you should see which compartment of this it fits into. Now, this is the cause of AK. This combines everything. So first going to pre-renal cause. Okay, so like I said, it can be hypovolemia. See, anything that leads to less blood supply into the kidney. So it can be hypovolemia, or it can be cardiac failure, or it can be hepatorenal syndrome. Okay, in hepatorenal syndrome, what happens? There's a detailed chapter coming about this. But in hepatorenal syndrome, what happens is there is splanchnic vasodilatation, right? So blood pooling occurs there, and less amount of blood reaches the kidney. So anything that leads to less blood supply to the kidney, that is pre-renal. Now coming to the renal artery. Okay, this is the vascular component where there is renal artery occlusion or dissection, large or medium vessel vasculitis. So in vasculitis, like if you go to the vasculitis chapter, we would have discussed this in detail, where the vessels are involved. So in that condition, acute kidney injury can happen. Okay. Similarly, if it is renal vein, just because I started artery, I'll finish off the vein also. If it's renal vein thrombosis, bilateral renal vein thrombosis can cause acute kidney injury. Unilateral generally does not cause. You have to remember this. It's generally bilateral. Okay. Now coming within the kidney. So here, if you see, they have taken a small section of the nephron and they have enlarged it. So here inside this, the small vessel disease like TMA or renal atheroembolism. Then you go to the glomerulus, which is all the causes of glomerulonephritis that which might be small vessel vasculitis, anti-GBM, lupus, IRGN, that is post-infectious glomerulonephritis, or infective endocarditis, membranoproliferative glomerulonephritis, cryoglobulinemia, and IgA. Okay. Next, coming to the tubule, ATN. ATN, acute tubular necrosis, can happen because of endogenous causes or exogenous causes. Endogenous causes is by rhabdomyolysis or intravascular hemolysis. Exogenous causes, let me just write this down. It can happen because of endogenous causes or exogenous causes. Exogenous causes are going to be because of any nephrotoxins or radiocontrast agents. Okay. Next is interstitium. So we finished the vessels, we finished the glomerulus, we finished the interstitium, we finished the tubule. Coming to the interstitium. Interstitium, acute interstitial nephritis. We have covered this in detail in the chapter of acute interstitial nephritis. Any drugs, infection, or systemic disease. Okay. Now, intratubular obstruction can happen again because of cast, like in multiple myeloma or some drug induced. So again, drugs or crystalluria. Now, post-renal obstruction comes in this part where there is coming from down, there can be bladder outlet obstruction. It can happen because of bladder CA. There might be some calculus in the ureter or somewhere here, or the kidney, the renal papilla can slough off, blocking the ureter, causing in renal papillary necrosis, or there can be retroperitoneal fibrosis blocking the ureter. So all these causes becomes the post-obstructive reason for acute kidney injury. Okay. So these are the causes of acute kidney injury. Now in the hospital setting, what are the causes? So here you can see the most common causes, acute tubular necrosis, followed by pre-renal. This is the second most common cause. After this, you see acute on chronic kidney disease and obstruction. The acute interstitial nephritis or vascular causes like renal artery thrombosis, atheroembolism are rare. Even RPGN is a rare entity. So remember, in hospital setting, the most common cause of AKI that we notice is acute tubular necrosis, followed by pre-renal, which can be because of hypovolemia or cardiorenal syndrome or hepatorenal syndrome, followed by acute on chronic kidney disease. Now, What happens in pre-renal acute kidney injury? What happens in pre-renal acute kidney injuries? There is impaired renal perfusion. This we already mentioned. Enough blood is not coming into the kidney. Okay. So why does enough blood not come into the kidney? One is there can be extracellular fluid volume depletion. This can happen because of GI causes like diarrhea, or it can happen because of renal causes like polyuria or using some diuretics. Okay. Or it can happen because of excessive loss from the skin like in burns. Okay. Or it can happen because of third phase sequestration of fluid. Okay. So this can happen in conditions like pancreatitis, or it can happen in conditions like dengue shock syndrome, or it can happen in rhabdomyolysis where large amount of fluid gets collected in one compartment. Okay. So one is because of volume depletion. The next cause is because of volume excess, but that excess is somewhere else not reaching the kidney, like in congestive cardiac failure where all the reverse back pressure, all the hepatic vein dilatation and IVC dilatation, renal vein dilatation is going to affect the kidney. Okay. Or it can be because of hepatorenal syndrome. Okay. In hepatorenal syndrome, again, like I discussed, there is going to be splanchnic vasodilatation. Okay. So this can cause reduced blood reaching the kidney. Now, what is the pathophysiology? Pathophysiology, what happens? There is reduced blood reaching the kidney. So kidney is going to try to reabsorb everything. So if you check urinary sodium, it's going to be less than 20 millimole per liter because there's going to be reabsorption of sodium and water. And urine is going to be highly osmolar urine, that is very concentrated urine because body is trying to excrete only little urine, minimal urine that is required to excrete the solutes, and sodium is going to be very less. And what is the difference that happens in this condition is because if this is the glomerulus, this is the afferent artery. Assume this is the capillaries and this is the efferent artery, right? Now what happens if more blood has to reach the glomerulus? This afferent arteriole has to vasodilate, right? So afferent arteriole undergoes vasodilatation. And if all the blood comes, it just goes away, there's no point. So what should happen to the efferent arteriole? It should vasoconstrict. So imagine two pipes like this through which the blood is flowing, right? Now you want more blood flow stay. Imagine a cup here, okay? Now you want more blood to stay in this area. So what are you going to do? You're going to increase the size of this pipe and reduce the size of this pipe. So the blood is going to stay here for a long time so that filtration occurs. So this is the concept that is happening in the body. So efferent arteriolar vasoconstriction happens, okay? Pathophysiology and etiology of postrenal AKI. So it can happen in patients who have some pre-existing risk factors with increased risk of forming stones, or patients who have some obstruction anywhere. So like we discussed, the causes of obstructive AKI. Okay. Now pathophysiology is there is going to be increased intratubular pressure, right? So what is going to happen if this is the glomerulus and this is the tubule, loop of Henle, distal tubule and collecting duct. And collecting duct, right? Now what is going to happen? The urine flow is going to be blocked. There's going to be increased pressure in the tubule. So always here in the glomerulus, there should be higher pressure than the tubule. Then only filtration will occur. So this increased intratubular pressure is going to oppose the glomerular filtration pressure. So filtration is not going to happen and reduce GFR. So here the pressure should be always higher than this tubule. Okay, so what happens is because this tubular pressure is high, the glomerular filtration does not happen. And because of this, the GFR reduces. Pathophysiology of acute tubular necrosis. It can happen because of ischemic injury or nephrotoxic injury. And when there is fever, it exacerbates ATN because metabolism increases. And if metabolism increases, all the channels are being used. If all the channels are being used, then more energy is required for the tubules, and this itself can lead to its death. So if it's uncomplicated ATN, generally recovery happens between 2 to 3 weeks. So this is what happens generally in ICUs. In wards, when we have patients with acute tubular necrosis and they're on dialysis, and if the patient attenders ask us that how long it will take for recovery, this is the general time span we give, 2 to 3 weeks. in uncomplicated cases. But imagine if there's a complicated case that the patient's stay in ICU is getting continued. Then in this situation, what is going to happen is repeated episodes of ATN or AK can happen, and this can worsen the acute tubular necrosis, and recovery might be much delayed. Now, renal biopsy. So this is what happens in acute tubular necrosis. This is a normal tubule. If you see here, you can see the brush border. These lines that you can see is the brush border. So this brush border here, you can see it is lost. Okay, so there will be loss of brush border. And here you can see the vacuolization. This is seen because of any acute tubular necrosis cause. And also these cells, these tubular epithelial cells are going to slough, and they're going to form a cast which is going to obstruct the tubule. Okay, necrosis per se is seen only in 10 to 15% of tubules, and otherwise we are going to see it in these findings. Now, where in the tubule is there maximum chance of acute tubular necrosis? So this has been asked as a question. See, the proximal tubule segment S3 and medullary thick ascending limb, these two come in the outer medulla, and these both are the place where maximum acute tubular necrosis is seen. Okay, not in the other places. So why is that? We'll see now. First factor is blood supply. We know that blood supply is mostly in the cortex. You can see that the PO2 is around 50 to 100 mg in the cortex. Okay, but as you go towards the medulla, the PO2 is dripping 10 to 20 mmHg, right? So most blood supply goes to the renal cortex, and medulla is just a watershed area receiving blood supply from vasa recta, and it is always in the brink of hypoxia because here the countercurrent system and the tubules are always running, right? Always working. So because of this, it's always going to be at the brink of hypoxia. And high tubular energy requirement among all the tubular parts, the highest energy requirement is in medullary thick ascending loop of Henle and in proximal tubule segment. Okay. So what happens is, once any cause of AKI comes, the kidney shuts off. As in these channels, these high tubular energy requirement, these channels, the sodium potassium 2 chloride channel and all the sympotors and antiporters are going to shut down. Okay. And the sodium potassium chloride channel. So the GFR decline is actually protective for the kidney. So it's the initial GFR decline is called as acute renal success. Next is the glycolytic capacity. Okay, medullary thick ascending loop of Henle, glycolysis happens. But in the S3 segment, it is oxidative phosphorylation. Okay, so this depends more on oxygen for its energy requirements. So because of all these reasons, because of the less blood supply and more metabolic demand because of all the channels, this place becomes maximally injured during acute tubular necrosis. Now that is the tubular factors. What are the hemodynamic factors in acute tubular necrosis? So there is something called as autoregulation in the kidney. That is, between 80 to 150 mmHg of pressure, the blood supply remains static. Okay. Now this becomes impaired in elderly and in patients with CKD. So what is the significance when it becomes impaired in elderly and CKD? It means that these patients, when autoregulation is impaired, even a small thing, a small impact can lead to acute kidney injury. Okay. And other thing that happens is intrarenal vasoconstriction as a protective mechanism. Intrarenal vasoconstriction occurs, which decreases the renal blood flow by 30 to 50%. Next is activation of tubuloglomerular feedback. That is, all the channels are going to reduce sodium utilization. So more sodium is go to the distal tubule, and more sodium is going to get sensed by the macula densa. It's going to release and activate the renin-angiotensin system, which will further vasodilate the afferent arteriole and vasoconstrict the efferent arteriole. Okay. So, and other mechanism that happens is reduced utilization of channels. Like I said, the channels are utilized in a reduced way because the metabolism is going to reduce. Now, these are the effects. Once there is renal ischemia, the vascular effects are seen. That is, there is increased cytosolic calcium in the glomerular afferent arterioles, which is going to lead to intrarenal vasoconstriction and impaired autoregulation. Endothelial injury will happen. This will reduce the nitric oxide, prostaglandin and endothelin. So, nitric oxide and prostaglandin, which especially prostacyclin, acts as vasodilatory factors which are reduced. Then endothelial cell swelling will occur, outer medullary congestion will occur. So, when the blood supply will reduce, the outer medulla will start getting congested. And this upregulation of adhesion molecules, because inflammation is started, adhesion molecules are going to get upregulated. So, this will increase the neutrophil adhesion and increase the reactive oxygen species. Now, all this endothelial cell swelling and outer medullary congestion will lead to hypoxia. Further, all these mechanisms together will lead to reduced GFR. Okay, this is just the pathophysiology. You don't have to remember this. Similarly, tubular factors. What happens is normal in the tubular lumen. This is the brush border. This is the basolateral border where there is sodium, potassium, ATPase and integrin. Once there is ischemia and reperfusion, you see that there is loss of brush border. That is, these channels are going to come here, that there is loss of polarity, and the brush border is also going to be lost. Okay. Finally, what is going to happen is some of the cells are going to undergo apoptosis. So when we call ATN also, mostly it is not necrosis. It's not necrosis that is seen, which can be seen only in 10 to 15% of cases. It is mostly apoptosis. Okay. Now coming to the systemic effects of acute kidney injury. Okay. In the once acute kidney injury happens, it can affect all organ systems. So in the brain, it can lead to uremic encephalopathy, increased blood-brain permeability, and further helping in uremic encephalopathy, and increased pro-inflammatory cytokines. In the heart, there can be volume overload and increased preload. So myocardial depression can happen, apoptosis of the myocytes, increased pro-inflammatory cytokines, and increased neutrophil tracking. In the gut, there can be nausea, vomiting, and malnutrition. Liver, there can be increased vascular congestion and permeability. Leukocyte influx can happen. There can be elevated transaminases because of the congestion. Okay. Bone marrow, there can be anemia. We know that basically there's going to be depression. So there's going to be anemia. There's going to be thrombocytopenia. There's going to be immune dysfunction. And in the lung, you know, there's going to be volume overload, increased vascular permeability, neutrophil sequestration, and increased pro-inflammatory cytokines. Now, how does recovery happen? Recovery can happen by restoration of the tubular cell and covering the denuded tubular basement membrane. So, if this is a tubular basement membrane, some cells are apoptotic, right? So, this will fall into the tubule. So, by restoring this denuded epithelium, by cells forming here, that's why we are going to restore the tubule. So, this happens by dedifferentiation and proliferation of the surviving tubular cells. Here in this picture, we saw that some tubular cells are surviving, right? So, this will dedifferentiate and proliferate into a new cell. So, that is how restoration is going to happen. And we know that neutrophils and monocyte cells are going to come to this area, and they also can help in restoration. Now, coming to each agent per se. First is nephrotoxic agents or NSAIDs causing acute tubular necrosis or acute kidney injury. So, see, non-specific NSAIDs and COX-2 inhibitors can cause AKI. It's nothing like COX-2 inhibitors will not cause. Even COX-2 inhibitors can cause AKI. So, what happens is, we know that in the glomerulus, there is afferent arteriole, there is capillaries and efferent arteriole. So, in the dilatation of the afferent arteriole, the prostaglandin or prostacyclin is required. So, when this is reduced because of NSAID, okay, so that is when what happens is afferent arterial vasoconstriction happens. But not everyone is affected by this. It's not like a younger person taking some diclofenac or aceclofenac is going to get AKI. So, who is the one who is going to get? The people in whom this afferent arteriole can be affected because of some pre-existing condition like diabetes or atherosclerosis. So, who are this? Elderly people or atherosclerosis. The second set of people is already in whom the endovascular volume is reduced. So, in them, even a small vasoconstriction can make a difference. Who are those? Patients with nephrotic syndrome, patients with cirrhosis, congestive cardiac failure and volume depletion. So, these are the risk factors. Okay. Now, this is a very important slide. This has been asked as a question multiple times. How NSAID can affect the kidney. Okay. So, we know pre-renal hemodynamic it can cause. When this pre-renal hemodynamic insult is lot, it can cause acute tubular necrosis, right? And it can also, when the blood supply reduces so much, it can cause papillary necrosis. So, that is about involving the vascular part, okay, the vascular part. Next is in the interstitium, it can cause interstitial nephritis, okay. So that you can remember. So, mostly you can find, not mostly, some of the times you can find these patients presenting as nephrotic syndrome plus AKI. And they will be having generally some two etiologies, okay. So, they are going to have some minimal change disease plus acute interstitial nephritis. So, this could be a possibility. Next is, it has sodium and water retention properties. So, it's going to cause exacerbation of hypertension and congestive cardiac failure. And because water is retained more than sodium, it can cause hyponatremia. It can also cause hyperkalemia, okay. So, these 7 are the manifestations of acute kidney injury. This is the 7 are the manifestations of NSAIDs in kidney. So, You start with the prerenal. If prerenal worsens, acute tubular necrosis. Then another necrosis that comes in is papillary necrosis. Then you see the interstitial compartment. It can affect the interstitial compartment. Then you think about its other fluid and electrolyte. That is, it causes sodium and water retention. So exacerbation of hypertension, exacerbation of congestive cardiac failure. Electrolyte is hyponatremia and hyperkalemia. Okay. Coming to the causes of acute tubular necrosis. So first is excessive prerenal causes can lead to acute tubular necrosis like antihypertensive agents and diuretics. Now renal artery, like we already discussed, the renal artery thrombosis, whatever. See, any prerenal cause when persisting for larger time, it can lead to acute tubular necrosis. Next, coming to the small vessel disease, like renal vasoconstriction can happen because of NSAIDs, AC inhibitor or ARB, contrast, calcineurin inhibitors, norepinephrine, cocaine. So all these will cause the afferent arteriolar vasoconstriction, the drugs causing afferent arteriolar vasoconstrictions. Okay. Next, the drugs causing thrombotic microangiopathy. This is gemcitabine, VEGF inhibitors, calcineurin inhibitors, CNIs, that is mitomycin, clopidogrel, quinine and OCP. So in the chapter of TMA, I have discussed all this. See, you don't have to worry about all this. When you finish the entire of nephrology, all these things easily you can remember. And you don't have to remember this for an exam, right? It's not like 1, 2, 3, 4. You have to remember the causes. So when you see this as an option, you must be able to pick up or you must be able to exclude based on this. So if you think of action, how these drugs act only, you will be able to guess in majority of time. So renal vasoconstriction is easy. TMA is difficult to remember. So when you hear it multiple times and even in TMA chapter, it will be easy to remember. But clopidogrel is quite common. It's asked also. OCPs. And also VEGF inhibitors. Okay. Now, next coming to the glomerular disease. Okay. The drugs causing glomerular disease are hydralazine, propylthiouracil, organic solvents, and levamisole adulterated cocaine, which can cause ANCA. Okay. So these are the drugs causing glomerular disease. This is a table showing drugs causing various conditions. So prerenal azotemia is antihypertensive agent and diuretic. Small vessel disease, we saw all these drugs causing small vessel disease. First is renal vasoconstriction. Second is TMA. Next is glomerular disease. The drugs causing glomerular disease, which are hydralazine, PTU, and levamisole adulterated cocaine, which is causing ANCA-associated vasculitis. Now, this is the same thing, the drug causing glomerular disease we already discussed. Now, drug causing acute tubular necrosis, which is amphotericin, aminoglycoside. See, don't have to remember, I'm just reading through, you don't have to remember these things. Foscarnet, these are the antiviral, tenofovir, cidofovir, adifovir, then cisplatin, ifosfamide, acetaminophen, heavy metals, herbal remedies, radiocontrast agents, pentamidine, organic solvents, IVIG, don't have to remember, not important. Again, AIN, so many drugs cause AIN. This thing, it's important. So, crystal formation, you can remember acyclovir, atazanavir, ethylene glycol because the oxalate crystals will deposit, methotrexate, triamterene, sulfonamide and high dose oral phosphate. So, as we go through the chapter, it will be easy for you to remember this also. Post-renal obstruction, the drug causing papillary necrosis is NSAIDs. Apart from this, we know diabetes can cause, tuberculosis can cause papillary necrosis, and urinary retention like anticholinergic agent and tricyclic antidepressants. Okay. Now, coming to each drug, how it causes AKI. Paracetamol, we know it causes glutathione depletion. So, glutathione depletion can affect the mitochondria, cause tubular injury, right? So, this is generally seen along with hepatitis when lethal dose of paracetamol is taken, generally after 3 to 4 days of ingestion. Treatment is glutathione depletion by N-acetylcysteine. Similarly, RAS blockers, it is hemodynamic effect. You know, there is dilatation of the efferent arteriole because dilatation of the afferent arteriole and vasoconstriction of the efferent arteriole is what protects the kidney in volume depletion. So, if there is reverse, if there is dilatation of the afferent arteriole by giving RAS blockers, then that can lead to AKI. Now, what are the risk factors? Not all develop this. So, if there is any situation of volume depletion, like the patient is having some diarrhea, patient is having some cause of diuresis, excessive diuretic, or patient is having some fever in those situations, or if patient is taking some coexisting thing like NSAID, some other nephrotoxic agent, or patient is elderly, then it can cause AKI easily. Okay, aminoglycosides, the next drug. So this is important. Aminoglycoside, what happens is, It is generally filtered from the glomerulus, and the cationic ammonium group of this aminoglycoside binds to the anionic megalin on the brush border of the proximal tubular cell. So if this is the proximal tubular cell, here there will be megalin channel, and here what happens, the ammonium, which is cationic, binds to this megalin. It enters the PTC and it destroys the cell. So generally, this is very important. It has been asked as a question multiple times. Generally, you see a non-oliguric AKI, which is generally seen 5 to 10 days after therapy. Okay, it is not seen immediately. You give therapy for 5 to 10 days. After that, you see, and urine output is maintained. Generally, the distal tubules are affected. Polyuria is seen, and potassium and magnesium wasting is also seen, because maximum potassium and magnesium, all this, the paracellular absorption of potassium and magnesium is happening here, and this is dependent on dose and duration of therapy. For example, multiple doses leads to more AKI, and if the duration is more than 10 days, it leads to more AKI. And this can occur even after the drug is discontinued, because once it goes to the tubule and it has done its damage, then it can persist even after we stop the drug. Okay. So risk factors, like we already mentioned, if patient is already on any nephrotoxic agent, multiple daily doses and longer duration of therapy. So we know if that is a risk factor, how to prevent it. Give a single daily dose. Okay. So gentamicin, tobramycin and netilmicin are more nephrotoxic than amikacin, which is considered less nephrotoxic in this spectrum. Now, coming to vancomycin. How does vancomycin cause nephrotoxicity? There is accumulation of vancomycin via the basolateral cells. Okay. Causing ATN. Some theory suggests that it can also cause DRESS syndrome. So basically it is ATN. Okay. What are the risk factors? When dose exceeds more than 4 gram per day, or in critically ill patient having many other comorbidities. Treatment is conservative. Sometimes high flux hemodialysis to remove the drug will help. Okay. Next is amphotericin B. Again, this is very important. It has been asked as a question. So what happens in this is in the tubules, there are going to be sterols in the cell membrane. So this amphotericin B, its mechanism of action is by binding to fungal ergosterols, right? So it binds to the steroid in the cell membrane also, and it increases its permeability. Once the permeability is increased, that is sterols, this amphotericin B binds to sterols. It increases the permeability of sodium. And once sodium permeability is improved, what happens? The sodium potassium ATPase is going to get overworked. And all this overwork is going to deplete the energy stores, and the cell is going to go to apoptosis. So this is what happens. And when the formulation of deoxycholate is used, what happens is it acts as a detergent on the cell surface. So this will further worsen the AKI. Okay. Now cumulative dose is around 2 to 3 gram. Hypokalemia and magnesemia can occur, which is because of distal wasting. When the 2 to 3 gram of cumulative doses cross, that is when nephrotoxicity is seen. And hypokalemia and hypomagnesemia, like in aminoglycoside, can happen because of distal wasting. Okay. And distal renal tubular acidosis happens because of back leak mechanism. There is back leak of proton into the cortical collecting duct. Now, prevention and treatment is to maintain high urine flow rate by hydrating well. Liposomal amphotericin B reduces the risk of AKI by 50% because it does not bind to the sterols in the cell membrane. And AKI is generally reversible, but hypomagnesemia is irreversible. That is important. Okay. So, it is also a non-oliguric AKI, and generally AKI is reversible, but the hypomagnesemia that you see along with this is irreversible. Okay. Now, coming to antiviral therapy, first is acyclovir. It causes tubular toxicity because of the crystals. This happens when it is given as IV or bolus. These are the risk factors. It is mostly oliguric AKI because it's an obstructive pattern, right? Intratubular crystals are seen and it recovers in few days after stopping the drug. Next is tenofovir. Tenofovir, what happens is it enters the proximal tubule via the organic anion transporter, okay, from basolateral surface. And it affects the mitochondria and the tubules. Now, this mostly we give it in retroviral patients, so it can happen weeks to years after starting the therapy. And it is known to cause Fanconi syndrome. We use a newer drug called as tenofovir alafenamide, which has lower chances of acute kidney injury. Okay. Next is atazanavir. Atazanavir causes crystals and acute interstitial nephritis, and it is mostly reversible. Now, coming to SGLT2 inhibitors. The mechanism is by accentuated tubuloglomerular feedback. I have discussed this in detail in the chapter of diabetes. and so I'm not going in detail here. So the other features is that generally it occurs within the first month of therapy, and some AKIs can be irreversible. And the risk factor is dehydration if there is any use of NSAIDs and if there is use of diuretics along with this SGLT2 inhibitors. Okay, so whenever we start, we make sure the patient is hydrated well, and the patient is not on any NSAIDs and patient is not taking any diuretic. Okay. Now, CNI, there can be reversible AKI and there can be afferent arteriolar vasoconstriction that is seen because of CNI. If it is not for AKI, all these can be the manifestations that is seen. Chronic striped interstitial fibrosis, arterial hyalinosis, hypertension, hyperkalemia, hyperuricemia, thrombotic microangiopathy, phosphorus and magnesium wasting. So, this is asked as a question and I have dealt this in transplant section. So, this is just a revision of what manifestations the CNI can cause. Now, other immunosuppressants, the ATG can cause cytokine storm and that can cause prerenal AKI. Sirolimus, generally it delays renal recovery. So, if there is a delayed graft function and sirolimus is started, then it can worsen that. IVIG, the sucrose containing IVIG can be toxic to the tubules and can cause ATN. Okay. So that is because of osmotic swelling of the tubule by sucrose. Next is ethylene glycol. We know ethylene glycol is broken down by alcohol dehydrogenase into glycolate and glyoxylate. And this glycolate and glyoxylate are the nephrotoxic contents to the tubule, and the oxalates can form crystals, right? So the treatment is anything that will utilize or block this alcohol dehydrogenase, like you can give IV ethanol or fomepizole. And if there is high levels of ethylene glycol, hemodialysis also will help to remove it. Okay. So this basically ethylene glycol can be diagnosed because it causes high anion gap metabolic acidosis because of accumulation of glycolate and glyoxylate, and also there is elevated anion gap. Now next is anticoagulant induced nephropathy. This happens when an anticoagulant like warfarin is given and INR is more than 3. There is going to be bleeding, that is glomerular hematuria. So these RBCs come and obstruct the tubule. Okay. So that will cause anticoagulant nephropathy. This generally happens in patients with underlying CKD. Acute phosphate nephropathy happens because of deposition of calcium phosphate crystals in the kidney. So this phosphate is going into the body by giving oral sodium phosphate purgative. Okay. So this happens in patients who have underlying volume depletions and CKD. Okay. So that is acute phosphate. Next is cocaine. The effect is it can cause AKI. One is by intense vasoconstriction causing hypertension. Second is rhabdomyolysis. Rhabdomyolysis can happen if they are in a cocaine-induced coma and there is pressure necrosis, or there is ischemic necrosis of the muscles because of intense vasoconstriction, or adrenergic stimulation causing hyperpyrexia. Okay. And sometime when this cocaine is adulterated with levamisole, it can cause ANCA vasculitis also. Now next, coming to contrast-induced nephropathy. This is commonly asked. So risk factors is any person. We know that contrast can cause afferent arteriolar vasoconstriction, right? So risk factors for this is any elderly, diabetic, or patient who already has volume depletion like congestive cardiac failure, volume depletion, or if we are giving contrast again and again, or any drug that is already causing afferent arteriolar vasoconstriction like NSAIDs, AC inhibitors. And it is seen that intra-arterial contrast, which can directly reach the kidney, like might be an angiogram, coronary or peripheral, that has higher effect of causing contrast-induced nephropathy than intravenous. Okay. Mechanism is there is afferent arteriolar vasoconstriction causing renal ischemia. There's also direct tubular toxicity. Okay. So what happens is there's initial vasodilatation and leading to after that prolonged vasoconstriction causing medullary hypoxia. Plus this contrast in the blood is going to increase the viscosity of blood, slowing the blood flow in all these areas. So because of all these reasons, the medullary hypoxia is going to worsen and there is going to be acute kidney injury. Now coming to the next section, which is heme pigment nephropathy. What happens is there is going to be rhabdomyolysis, that is releasing the myoglobin, and there's going to be massive intravascular hemolysis. Okay, or there's going to be massive intravascular hemolysis. So it is going to be either myoglobin or hemoglobin. Okay, this massive intravascular hemolysis can happen in incompatible blood transfusion, autoimmune hemolytic anemia, or malaria. Now these are the various causes of rhabdomyolysis. First is muscle injury or ischemia, because that is a major source of myoglobin, right? So it can happen when there is a trauma or pressure necrosis, like patient is comatose, or electric burns or acute vascular disease causing any necrosis of the muscle. Okay, so that's muscle injury. Or myofiber exhaustion, that is the muscle is overutilized, leading to excretion of myoglobin into the blood. So this happens when there is seizure or excessive exercise. So this we see in marathon runners or heat exhaustion. Next is if there are some toxins that can lead to rhabdomyolysis, like alcohol, cocaine, which we already discussed, other drugs like amphetamines, ecstasy, phencyclidine, snakebite and heroin. Okay. Next, there are drugs which can cause rhabdomyolysis like statins and fibrates, especially when given together in CKD patients, zidovudin, neuroleptic malignant syndrome, azathioprine, theophylline and diuretics. So important thing that you have to remember is statin, fibrates and zidovudin. Okay, so these three are the drugs that can cause rhabdomyolysis. Then electrolyte disorder like hypophosphatemia, hypokalemia and hyperosmolar states. Okay. So we have actually seen clinically that in all these conditions, when there is hypophosphatemia, hypokalemia and hyperosmolar state, patient coming to us with rhabdomyolysis. Next is infections, like if there is influenza, HIV, Coxsackie, Epstein-Barr virus, that one, or there is bacterial like Legionella, Francisella, Streptococcus pneumoniae, Salmonella, Staphylococcus. You don't have to remember infections, but you remember viral and bacterial can cause rhabdomyolysis. And familial like myocardial disease, CPMT deficiency or malignant hyperthermia. So when they are presenting with recurrent rhabdomyolysis, we can, or with family history of rhabdomyolysis, we can suspect familial disease. And others are like hypothyroidism, polymyositis, dermatomyositis. In this entire list, you can remember the toxins and the drugs. Drugs also 3: statins, fibrates and zidovudin. Okay. Now what happens exactly, how does AKI happen in this condition? Okay, so I think there is a compartment syndrome leading to muscle injury. Once there's muscle injury, lot of fluid is going to get sequestered in that area. So once fluid is there more in that area, less fluid is going to go into the kidney. So there's going to be volume depletion and renal hyperperfusion. It also leads to renal vasoconstriction. Okay, next is inflammatory cascade is going to get stimulated, which is going to again lead to renal vasoconstriction. Myoglobin is going to get released, which because it scavenges nitric oxide can cause renal vasoconstriction. It goes and sits in the tubule causing obstruction, and it can directly be toxic to the tubules because heme protein mediated tubular toxicity can happen. Okay. Similarly, in severe hemolysis, when there is hemoglobin, this protein is going to go affect the tubule and causes direct toxicity. So it can be direct toxicity. It can be because of sitting in the tubules, that is because of the cast. It can be renal vasoconstriction. Finally, all these things lead to ATN. Now next is renal artery or vein occlusion. Generally, if there is AKI, that means there is bilateral renal artery involvement, or if there is a single kidney, it can be unilateral. Thrombosis or embolism happens generally when there is atrial fibrillation or aortic dissection. Renal vein thrombosis also AKI happens if it is bilateral. Okay. Next, coming to AKI in sepsis. It is mostly seen in critically ill patients. That is 50% of patients having AKI in ICUs because of septic AKI, and once these patients go into dialysis, 50 to 60% is the mortality rate. That is quite high. So what is the mechanism? Initially it was thought as pre-renal, but now it shows that it is because of direct injury to the tubules, like molecule release from the pathogen, lipopolysaccharide, lipoteichoic acid going and affecting the proximal tubule, or it can be injured cells which activates the inflammatory response like cytokines and the coagulation system causing this, or there can be disruption of renal microcirculation because the procoagulant system is activated causing focal ischemia. There is efferent arterial vasodilatation that is causing fallen GFR. So it was seen that when vasopressin was given, this thing was reversed. That is, AKI patients had less chance of AKI because it causes efferent arterial or vasoconstriction. Now in trauma, how AKI happens? It can happen because of rhabdomyolysis, because of any hypovolemic shock, abdominal compartment syndrome and direct trauma to the kidney. Okay, to kidney. Next, AKI after cardiac surgery. Generally after cardiac surgery, AKI is seen in bypass surgeries. What happens is the blood goes into the bypass, which is not endothelium. So when it gets exposed to that, inflammatory system gets activated, procoagulant system gets activated, and it affects the kidney. Sometimes there is hemolysis also that is seen, which will cause hemoglobinuria. Okay. Next is aortic cross clamping, that when it is done, it can cause atheroembolism because there can be atherosclerotic plaques in the aorta which gets dislodged during clamping. and also the reduced blood supply during the clamping also can cause this. Okay, perioperative MI or left ventricular dysfunction causing low cardiac output, further leading to AKI. So these three are the mechanism by which cardiac surgery can cause AKI. Now after vascular surgery, generally abdominal aortic aneurysm repair is what is going to cause this. It is seen mostly after open repair more than endovascular repair, and ischemic ATN can be seen because there is going to be aortic cross clamping, and there is going to be thromboembolism or there is going to be atheroembolism and contrast nephropathy. Now abdominal compartment syndrome, what happens is the intra-abdominal pressure elevates to more than 20 mmHg. So this compresses on the renal vein, and what happens is there is going to be increased renal venous pressure and vascular resistance. So the blood is not coming out of the renal vein. So that increases the pressure inside the kidney and that causes AKI. Okay. So to measure the intra-abdominal pressure, we actually measure the intravesical pressure. Okay. Now this is seen in trauma or when there is excessive surgery or when there is excessive fluid resuscitation. Now next, coming to causes of pulmonary renal syndrome. This also I have discussed in the chapter of ANCA vasculitis. I am not going into detail of it. We know that it can have immunologic cause and drug-induced causes. Immunologic causes can be anti-GBM disease or ANCA vasculitis, that is small vessel vasculitis, which can be either GPA, EGPA, or it can be microscopic polyangiitis. Immune complex diseases like lupus, IgA, mixed cryoglobulinemia and rheumatoid vasculitis, and drugs like penicillamine, hydrolysine and propylthiouracil. These all can cause vasculitis. Again, infections like something that is affecting both lungs and the kidney, like pneumonia, PIGN, Legionella, leptospira, hantavirus and all that. And pulmonary edema and acute kidney injury, like when there is volume overload because of heart failure. And multi-organ failure, other causes like paraquat poisoning. Okay. Now in liver disease, this will again deal in the chapter of AKI in liver disease. Pre-renal azotemia can happen because we are using excessive diuretics, or there can be GI loss or large volume paracentesis or hypoalbuminemia. Again, hepatorenal syndrome can happen. ATN can happen because of bile cast nephropathy. This is important to remember. And drugs that we use that can cause acute kidney injury. Infections that are coexisting like hepatitis C causing cryoglobulinemia, hepatitis B causing polyarteritis nodosa, leptospira, hanta. All these viruses can cause both liver and kidney damage. Now in patients with cancer, what could be the cause? Okay, the most common cause is going to be nausea and vomiting, that is pre-renal. Hypercalcemia like in multiple myeloma. There can be cardiomyopathy secondary to chemotherapy leading to this pre-renal cause. Again, vascular event like thrombotic microangiopathy can happen. It can happen because of the disease or because of the drugs. Disease is adenocarcinoma of the stomach or any solid organ like breast, prostate, lung, pancreas, radiation nephropathy. All this can lead to vascular causes, that is TMA. Glomerular RPGN can happen. Acute tubular necrosis because of sepsis and toxicity of any drug that is given. Malignant infiltration of the kidney like in lymphoma and ALL. Intraluminal obstruction like in tumor lysis syndrome. So this is one important thing that you have to remember. So tumor lysis syndrome, that is very important to remember. So we'll go in detail about that. Tumor lysis syndrome is generally seen when obviously there's a malignancy or a tumor. Generally after treatment of Burkitt's lymphoma or some solid tumors. Okay, generally it is seen after treatment, but sometimes it can be seen spontaneously also before treatment. This happens when the tumor is rapidly growing and the blood supply is very less for it. Okay, so mechanism is when there is necrosis of the tumor cells, there is a release of large quantity of intracellular substances like phosphorus, maybe uric acid and potassium. So what happens is there is formation of crystals in the tubule. So it can be uric acid crystals, it can be calcium phosphate crystals. These are going to be nephrotoxic, and there is going to be hyperkalemia. Okay, so this hyperkalemia can be very large in quantities and it can be life threatening. And second thing is there can be renal vasoconstriction. This can happen. Okay, so risk factors is if the patient already has a pre-existing CKD and is not able to manage the load of uric acid, phosphorus, or if it's a bulky and rapidly growing tumor which can lead to large amount of tumor necrosis, and patient already has some volume depletion and acidic urine which will precipitate the crystals. Okay, so all these will become the risk factors. Okay, now clinical features are there because there is going to be crystal formation, the urine output is going to reduce. oligoanuric AKI, there's going to be lysis, right? So LDH is going to be high. There is going to be hyperkalemia, hyperphosphatemia and hyperuricemia. So these three things can be seen. Okay, so that's about tumor lysis. Next, coming to the effect of chemotherapeutic drug, cisplatin, it generally causes non-oliguric AKI, it causes ATN. See, generally if you remember a drug, you don't know what mechanism it causes, it mostly will be causing ATN, okay? Except for the drugs that produces glomerulonephritis or vasculitis, like propylthiouracil or hydrolysin or levamisole adulterated with cocaine adulterated with levamisole, all these drugs. So apart from it, if you can remember, mostly this will be causing ATN, okay? Prevention is by doing volume loading. Again, ifosfamide, it is known to cause Fanconi syndrome. Methotrexate can cause crystals. So it can be prevented by alkalinization of urine and hydration. And gemcitabine, we know it causes TMA. So among the drugs that cause TMA, like we saw here, gemcitabine is one of the causes. Others, cisplatin, CNI, anti-VEGF therapies can cause, okay. So see, this is about the etiology and pathogenesis of how each of these things happen. Now, management of each of these things, I'll come in the next chapter, okay.